These are my disclosures. Thank you, Paul, again for the invitation, and also a fantastic conference. We're going to talk a little bit about fusion imaging to address challenges for mitral therapy, and these are my disclosures as we talked about. So as we're progressing towards mitral valve interventions, we're increasingly reliant on multiple imaging modalities. It not only applies to screening and diagnosis, also for pre-procedural planning and also for procedural guidance as well. So as you know, there are numerous limitations for each modality. For example, for fluoroscopy, it lacks the three-dimensional depth. Also, there's increased use of radiation, contrast use, and things like that. And if you look at CT and MRI, they're not real-time. CT, as you know, has radiation risk. MRI has poor spatial resolution. And one of the most used modalities, which is the TEE, is very useful, but has a small field of vision, and also needs better spatial and temporal resolution as well. Especially if you're looking for wires while doing the procedures, it can't be well visualized. So in essence, there is not a single modality that can give you all the information while doing these procedures, and that's when fusion imaging plays an important role. So to basically define fusion imaging, it's a process of purposefully merging selected and task-relevant and complementary information from two or more imaging modalities to guide, inform, or facilitate imaging-guided therapies. It's a mouthful, but it sort of encompasses most of the things we do with fusion imaging. So in this process, as you see above in this particular slide, so there are two ways in this particular here. There's pre-acquired to live fusion, which is mainly done with CT. There's a lot of advantages here because you can determine the projection angles, also look at, it reduces the direction of trial and error, and identifies regions of interest. You can form annotations, trajectories, but one of the main limitations of pre-acquired is it lacks motion compensation because it's not live. So that's the advantage of having a live-to-live fusion with 3D TEE and fluoroscopy, where you simultaneously fuse two imaging modalities that are acquired simultaneously, which is mostly done with TEE in this particular case. But as we talked about, it's a small volume 3D data with TEE. There is various aspects of fusion imaging. Mainly, we want to look at selective information that can be displayed, whether it is the boundaries of cardiac structures, various structures here in this case, maybe LV may be relevant, mitral valve, left atrium, you don't want the aorta in the place, or on the right side structures being in place. So you can selectively adapt what structures you want to display. You can also select what the transparency of the structures is there so that you can see the visualization of one of the fluoroscopy better. So oftentimes we can use more physiological information, especially using color Doppler. And if you want to locate the paravalvular leak or understand how much leak is left, it gives an added information. And one of the most useful nature of this fusion imaging is the ability to identify regions of interest. So if you want to go after paravalvular leaks, you want to know in three-dimensional space where exactly it is. So you can annotate these areas of interest in one of the modalities, so you can overlay that into fluoroscopy, so you have one region of interest where you can use your catheters, direct your catheters. So the same thing with understanding where you can place your virtual devices. So as Dr. Calverte was showing, you can actually create STL files of devices and actually superimpose them on your live fluoroscopy. So you can understand where you want to place your devices and also where you want to, how it looks like after your procedures. This is the process of fusion imaging. So we start with a tailored EKG-gated CT acquisition, which needs higher resolution scanners, needs appropriate contrast volume and timing. And then you do a process called CT post-processing with using, here in this case, Heart Navigator from Philips Healthcare. We are doing an automated segmentation of the CT data. We're color coding various different structures through the software, and we can manually correct or add some structures as needed. Then this model can be actually used in its entirety or its chambers of interest. Initially, you can manipulate the transparency as we talked about. There are various tools that you can use. You can manual rotation, cut planes, zoom measurements, and things like that to manipulate these whole volume. So in addition, we talked about placing virtual devices. Here, the STL fails in direct shape and three-dimensional shape of the devices can be actually superimposed on this particular pre-planning. So how does fusion actually work? One of the most important things one needs to do is registration. What it basically means is the process of adjusting position of the 2D and a 3D CT or a 3D TE data or image over fluoroscopy to match the scale and orientation in three-dimensional space. So this is what your monitors look like when you have 3D fusion. Sorry, fusion as such on a whole. You have a patient monitor with all your data, TE, fluoroscopy fusion. You have, if you don't like that to be displayed, you have a regular fluoroscopy in there for people who are too much information. And you also have CTA and fluoroscopy information as we talked about. So there are two different distinctions with the TE and CTA. So with CT, the registration aspect is actually done by using internal markers where you manually adjust this positioning. Or if you don't have any internal markers, you have to use aortic root angiography. With TEE, is much more clever. It automatically identifies the TE probe and uses that for orienting your three-dimensional position. So coming to the mitral valve, there are various aspects of the mitral valve therapies that you can use fusion imaging for. So one of the most important of the mitral valve therapy is access. So you can either need a transseptal access or a transapical access. Just in terms of transseptal access, we're seeing here a TE fluoroscopy fusion and CTA fluoroscopy fusion. With the TE in particular, you can actually make annotation markers at the site of the transseptal punctures, which is then overlaid onto fluoroscopy, so you can direct your catheters and wires that you see on fluoroscopy to this particular area of interest. So it is the marker for you in terms of doing the procedure. Transapical procedure can be a little bit more complex. Here we overlaid an anatomical model of the 3D heart and adjacent structures on with good orientation and 3D shape onto the fluoroscopy. Now, not only that, we created a cylinder from the access site of the skin to the marker of interest, which in this case is the PVL. So you have a cylinder through which you can put your needle through. And so you start off here at the start, where you show it as a bullseye, so you can actually make use your needle to go in, and then you turn it to horizontally, so you have a cylindrical track where you can actually direct your needle through. You can use a contrast as well. So the basis of doing this for access is you avoiding collateral damage. So you can actually segment your lungs, display the lungs in there. If you need to drop the lungs, you can always do that. The other access region of interest here is the LAD. You can actually segment the LAD as well. So it is also useful for closure from transapical sites. So you can actually segment your endocardium, epicardial sites. So you can flip-flop between these two to understand where you're actually deploying your plug that you need to. So you can also use for MitraClip. This is a TE fluoroscopy fusion. It's a live fusion here. So here we're doing a couple of things. We're marking a region of interest, which is the MitraClip and the region of interest that we want to address. So then it's overlaid onto the fluoroscopy, the marker as it moves, so you can actually direct your MitraClip catheter. But more importantly, I want you to take a look at the small green probe that exists. So that's how the fluoroscopy TE fluoro fusion works. So it identifies the TE marker and then turns green, and so you know that. Then you have various aspects of the 3D TE itself that you can overlay. So now you can make a cubical structure on the top, or you can do a 2D information, physiologically color Doppler, as well as 3D information as well. So there's more advances with the TE fluoroscopy fusion with the Echo Navigator. It's called anatomical intelligence. Now TE Live can create, auto-generate some of the structures, mainly LV in here and also LA, to sort of give the operator a little bit more confidence as to where he relies in terms of overall procedural aspects itself. As we talked before, a lot of physiological information, especially color Doppler, can be displayed right on top of your screen. This is useful, especially if you're doing a PVL or a MitraClip. You want to know how much leak there is and where it is, and gives them that additional amount of information that one needs. So PVL guidance is one of the most useful ones for these particular ones, especially access as we talked about, crossing the PVLs. Anatomical orientation of these PVLs is certainly difficult on the mitral side. So if you place your markers, pre-plan the markers before, then you can put them on position. As you move your fluoroscopy, the markers stay in place in three-dimensional space. So it's easier for your operators to use your guidance in the wires to use that markers to cross across, also while placing the devices as well. In a similar way, here is a arteriovenous rail over which a valve-in-valve implantation of the mitral valve is being performed with a sapien valve. And here, as we're talking about the transparency of the structures, now you see a fully opaque structure immediately becomes transparent as you manipulate, so you know where you stand in terms of your fluoroscopy. Understand, you still have an overline, borderline of the heart, but still visualize the catheters and things like that. So here, we are showcasing the same with the TE fluoroscopy, so you have multiple imaging modalities as you go. So as we go forward, how do we utilize fusion imaging with a newer device as well? As many of you know here, Neochord system is for degenerative MR, where you anchor one of your cords from the leaflet to the LV. So a lot is dependent on where you actually take apical axis, and it's important to identify the structures of the lungs of the LAD to exactly pinpoint where your axis site is going to be on the LA, and this plays a huge role. Additional to that, there is also anterior lateral papillary muscles as well as posterior medial that one has to take extra precaution as well. So here, in this modeling, you can actually create the whole segmentation of the heart, and you can also create the segmentation of the papillary muscles, and then actually create a trajectory from the skin out into the muscles that you can use to perform the punctures. As Dr. Lim was talking about, which is the Acusyn system, which is a very innovative system that you use to deploy an annuloplasty device that you can place below the mitral valve. Again, you can have an annotation of the Acusyn system, so you know where exactly to place the system. Sometimes it's very difficult to know how low or how high we're going with this particular one. So, no surprise, so it needs a lot of information for transcatheter mitral valve therapy. You can pre-plan the full axis and also simulate some of the STL files and simulate pre-hand to sort of identify the positioning as well as post-success rate of the results. Especially with 10-9-1 comment is if we're going to transeptal 10-9, I think a huge part of it would be trying to find a percutaneous aspect to transapical axis. And the future directions we're looking at, some of this is motion compensation from the CT. If we can identify a way to use a multiphasic fusion, that'll be great. And also to reduce the amount of contrast and radiation, if we can fuse TE to CTA. This is a simulation of a case we had, which is there was a deletion of the repair here, which was corrected surgically. So thank you very much.